Welcome to this clinical teaching presentation from Professor Mohammadi's Teaching Archives. Today we will discuss an important and challenging pediatric neurology case, infantile Krabbe disease. This presentation follows a realistic clinical vignette and highlights how early symptoms, diagnostic clues, and treatment timing come together in clinical decision-making. Krabbe disease can be difficult to recognize at first because the earliest symptoms may look like common infant problems, such as reflux, colic, feeding difficulty, or irritability. The key is to notice when these symptoms occur together with developmental regression and abnormal neurologic signs. By the end of this presentation, the central message should be clear. In infantile Krabbe disease, early recognition matters because the window for disease-modifying treatment is extremely narrow. Once the infant is clearly symptomatic, management priorities shift towards supportive care, symptom control, family counseling, and urgent testing of future or newborn siblings. This case begins with a 4-month-old boy who presents with progressive irritability, feeding difficulty, poor weight gain, and developmental regression. At first, these symptoms could easily be attributed to reflux, colic, or feeding intolerance. However, the clinical picture becomes much more concerning when the parents describe loss of head control, reduced social smile, exaggerated startle, and worsening distress with handling. On examination, the infant shows axial hypotonia with limb spasticity, persistent fisting, scissoring, brisk knee reflexes, absent ankle jerks, opistotonic posturing, and poor visual fixation. This combination is highly significant. It suggests both upper motor neuron involvement and peripheral nerve involvement. The important clinical lesson is that ordinary infant symptoms become urgent when they occur together with regression and mixed central and peripheral neurologic signs. This is the point where the pediatrician or neurologist must move beyond common explanations and consider a neurodegenerative or leukodystrophy process. Next slide, please. Several red flags in this case point toward infantile Krabbe disease. The first is severe irritability and hypersensitivity to handling. In this setting, irritability is not simply colic. It may reflect neurologic discomfort and progressive demyelination. The second red flag is developmental regression after initially normal early development. Regression changes the differential diagnosis dramatically. It moves the case away from isolated feeding problems and toward progressive neurologic disease. The third clue is the combination of central and peripheral signs. Spasticity, brisk reflexes, and posturing suggest central nervous system involvement, while absent ankle reflexes and later nerve conduction abnormalities suggest peripheral neuropathy. Finally, feeding dysfunction and visual impairment indicate more advanced neurologic involvement. The key reasoning step is to avoid anchoring on reflux, colic, or epilepsy alone when the infant is globally regressing. Next slide, please. The diagnosis is built from a converging pattern rather than from one isolated test. The CSF shows markedly elevated protein without pleocytosis, supporting a non-inflammatory demyelinating process. Nerve conduction studies show a demyelinating sensorimotor neuropathy, which helps explain the absent ankle reflexes. The MRI shows symmetric white matter abnormalities, with involvement of deep white matter and corticospinal tracts. This pattern supports a leukodystrophy rather than an acquired focal lesion. The biochemical and genetic results then confirm the diagnosis. Leukocyte GALC activity is less than 2% of normal. Blood psychosine is markedly elevated, which strongly supports infantile onset Krabbe disease. Molecular testing identifies biallelic pathogenic GALC variants. The confirmatory logic is therefore low GALC activity, elevated psychosine, and pathogenic GALC variants, all in a child with a compatible clinical and radiologic phenotype. Next slide, please. MRI and neurophysiology are especially helpful in recognizing this condition. The MRI pattern shows symmetric periventricular and deep white matter abnormalities with tract involvement. This reflects central myelin injury. At the same time, the nerve conduction studies show demyelinating sensorimotor neuropathy. This peripheral involvement is a major clue. It explains why the infant can have absent ankle reflexes even while also showing pyramidal signs such as spasticity and brisk knee reflexes. Cranial or spinal nerve root enhancement can also be seen and may support the diagnosis. In clinical reasoning, the strength of the diagnosis comes from matching the imaging pattern, peripheral nerve findings, CSF protein elevation, and the biochemical genetic confirmation. Next slide, please. The pathophysiology helps explain the clinical presentation. Krabbe disease is caused by deficiency of galactocerebrosidase, or GALC. This leads to accumulation of psychosine, which is toxic to oligodendrocytes and Schwann cells. As a result, both central and peripheral myelin are affected. Central demyelination produces regression, spasticity, poor visual function, posturing, and progressive neurologic decline. Peripheral nerve involvement produces demyelinating neuropathy and loss of distal reflexes. This is why the case is so clinically distinctive. It is not just a leukodystrophy, and it is not just a neuropathy. It is a disorder that affects both systems. Diagnostic confidence rises when clinical regression, MRI leukodystrophy, peripheral neuropathy, low GALC activity, elevated psychosine, and pathogenic GALC variants all converge. Next slide, please. The most important management question is whether this symptomatic infant should undergo urgent hematopoietic stem cell transplantation. This is where timing becomes critical. HSCT is the only established disease-modifying therapy for infantile Krabbe disease, but its benefit is greatest when performed before symptoms develop, usually in the newborn period or very early infancy. In a clearly symptomatic infant with dysphagia, visual impairment, painful spasms, and progressive neurologic decline, late transplantation is unlikely to reverse established injury and may add significant treatment burden. Therefore, the best next step is multidisciplinary supportive and palliative-centered care. This includes feeding and aspiration management, nutritional planning, possible gastrostomy discussion, pain control, spasticity and dystonia treatment, seizure surveillance, respiratory planning, and careful family support. The common trap is to assume that because HSCT is disease-modifying, it must always be urgent. In Krabbe disease, stage and timing determine whether transplant is appropriate. Next slide, please. Family counseling is a central part of management. Krabbe disease is inherited in an autosomal recessive pattern. If both parents are carriers, each future pregnancy has a 25% risk of being affected. This means that the most actionable intervention may be for a future pregnancy or a newborn sibling, rather than for the already symptomatic index child. Once the familial variants are known, parents can be offered carrier testing, family testing, prenatal diagnosis, and pre-implantation genetic testing. Future or newborn siblings should be tested urgently because the therapeutic window for HSCT is narrow. A pre-symptomatic affected newborn may benefit from early referral and rapid transplant evaluation. This is a key teaching point. For the symptomatic infant, care focuses on comfort, safety, and family support. For a future or newborn sibling, early diagnosis may create the opportunity for disease-modifying treatment. Next slide, please. This case can also be used as a high-level key features assessment question. The question asks, a symptomatic 4-month-old has confirmed infantile Krabbe disease. What is the best next step? Urgent HSCT is not the best answer once the infant is clearly symptomatic, because transplant benefit is greatest before symptom onset. IVIG and steroids would be inappropriate because this is not an acquired immune neuropathy. Enzyme therapy is not established standard treatment in this situation. Anti-seizure medication alone would miss the underlying leukodystrophy and would not address the broader disease process. The best answer is supportive care plus family testing. This choice reflects the essential clinical synthesis. The diagnosis is confirmed, the infant is already symptomatic, and management must now prioritize comfort, feeding safety, neurologic symptom control, family counseling, and urgent testing of future or newborn siblings. Next slide, please. Let us close with 5 key take-home messages. First, regression after initially normal early development is always a serious warning sign. Second, Krabbe disease affects both central and peripheral myelin, so mixed upper motor neuron and peripheral neuropathy findings are diagnostically important. Third, confidence in the diagnosis comes from converging evidence: MRI, CSF, nerve conduction studies, GALC enzyme activity, psychosine level, and genetic testing. Fourth, HSCT is time-sensitive and is most useful before clear symptoms develop. And fifth, for a clearly symptomatic infant, management should focus on comfort, safety, feeding support, symptom control, palliative care, and genetic counseling. Clinical excellence in this condition depends on early pattern recognition, timely diagnosis, and stage-appropriate management. Thanks for watching!